Dr. Kahn is going to talk to us today in general about the field of cancer surgery and perhaps with her own special interest in breast cancer. Dr. Kahn.
Right.
Can I just take that one?
Actually, I would recommend using this.
Oh, okay.
Sorry.
All right.
Because we're recording it, so there's
Okay. Is that on? Yeah. All right. I'm sorry I am late. I misjudged the difficulty of finding this place. So, as Dr. Licht said, my major clinical interest is in breast cancer, and I was asked to talk to you about surgical oncology successes and failures. So I'm going to basically put this in the context of breast cancer, but a lot of what I say about breast cancer really applies to pretty much any solid tumor. As you may or may not know, breast cancer has actually been in the vanguard for a lot of research in both clinical management as well as cancer biology. And many of the first trials for solid tumors were done in breast cancer. So the first adjuvant therapy trials, the first screening trials, the first prevention trial, large randomized trials, and so on. So there's actually a lot of level 1 evidence for the management of breast cancer. It's a very nice model for sort of developing innovations in other tumor fields as well. So we can certainly talk about other tumors, but I'm going to present most of the information related to breast cancer. So this model of the normal epithelium progressing to invasive malignancy actually applies to many solid tumors. So the normal gland has usually a single cell lining with hyperplastic lesions, some cell proliferation. It then may progress to atypical hyperplasia. Atypical hyperplasia is a really strong risk factor for breast cancer. Women who have it will have a 4- or 5-fold increased risk of breast cancer in the future, and similar lesions exist in pretty much all other organs that are susceptible to solid tumor formation. So atypical hyperplasia is an important risk marker. The first thing we consider a malignancy is this non-invasive cancer or in situ malignancy, where there are neoplastic proliferations. They're often monoclonal. They have many of the features of invasive cancer cells, but they have not acquired that critical ability to break through natural barriers. The basement membrane is intact, and these cells are proliferating within the ductal structure. And this happens again in prostate, in colon, in a number of other organs. And then invasion, of course, is the ability to invade through natural barriers. There are many steps that are involved in acquiring this invasive phenotype that have been worked out on the biological level in breast cancer and in other solid tumors. But again, there's a lot of interesting information in breast cancer. I won't dwell on that today. But returning to sort of clinical surgical oncology, these are two giants in the area of breast cancer, sort of clinical management, understanding, research, that have really dominated the field over the past century and more. And there are, of course, similar figures in other areas, but these two men influence the development of clinical surgical oncology really very dramatically. So up here is William Halstead from Hopkins. About, I think his 100th birth anniversary was about 10 years ago. So he was born about 110 years ago. He really influenced ideas about cancer progression towards the end of the 19th century. ideas that prevailed through the middle and latter part of the 20th century. And he basically felt that breast cancer is a local disease. His definition of local was very broad, from the cranium to the knees. I'm not sure exactly how that's local, but he thought of it as a local problem that progresses in an orderly fashion from the breast to the lymph node, to the axillary lymph nodes, the supraclavicular nodes, to other nodes, and then from there on to other organs. Whereas the iconoclast who came along in the middle of the 20th century, who really started questioning these ideas, first in animal experiments in the laboratory, and then in clinical experiments that he designed that have really influenced a whole generation of surgical oncologists, was Bernie Fisher, who ran one of the earliest clinical trials groups, the NSABP, the National Surgical Adjuvant. It was originally the Breast and Bowel Project. Actually, they still do some bowel studies, but anyway, known as the NSABP. And he articulated this idea that breast cancer is a systemic disease. So the swing of the pendulum that I have there in the background, that breast cancer is a systemic disease at diagnosis. The metastatic phenotype is really determined at the onset. It is either present or absent. It's not acquired over time. And as a result, he's persuaded many of us that it really didn't matter what you did to the local tumor in the breast. The outcome was really determined by what happened elsewhere in the body, so the systemic manifestations. Now, this idea was, through some of the studies that I'll talk about in a minute, became pretty well accepted in the breast arena, but was not so well accepted in other solid tumors, although these are the two extremes in terms of concepts of solid tumor biology. But other solid tumors also have similar dichotomy of systemic versus local, how important each one is, and how long that phase of local growth is before the disease becomes systemic. So this is still a burning question and still something we're trying to define. And more importantly, we're trying to define it not in terms of a monolith of breast cancer or rectal cancer or colon cancer, but realizing that in different individuals, according to the host environment and many other features of individual tumor biology, that time point may actually be different. So you can have a really tiny breast cancer that can be systemic at outset, and you can have a 5-centimeter breast cancer that's still local. And so these are concepts that are still evolving. So Bernie Fisher took us sort of to the other end of the pendulum. And now we're sort of back in the middle, and I'll talk about this 1 in 4 rule that's been articulated recently in a minute. So surgeons were the original oncologists, certainly Halsted and his peers. Halsted is sort of the most well-known of that group, but there were many others who thought similarly and made important observations. And the success, I would say, in thinking of a single success to apply to surgical oncology management over the past 50 years or more, has been the idea of organ preservation. The idea that one can treat cancer effectively while maintaining organs intact to a greater or lesser degree. This applies to the breast, of course. It also applies to other organs, the stomach, the rectum, the anus. There are a whole host of examples of this, the extremities in sarcoma. But the idea that one can treat cancer while preserving organ integrity and also thereby maintaining quality of life and limiting the morbidity of the treatment. So that's been really the big advance, I think. I mean, surgeons were thinking about large resections of tumors for many, many years. We're doing it, but what surgeons are trying to do now is to really intelligently limit the resection. And that's where we can use a lot of help from chemists, from engineers, from molecular biologists, from experimentalists of a variety of disciplines, is how to intelligently limit what we do to a patient surgically and still cure the tumor. So this is a landmark study in breast cancer, the NSABP B06 trial, the one that, actually Dr. Fisher did a number of important trials before this one, but this is really his sort of signature trial. And it was to test the idea that mastectomy was not necessary for the treatment of breast cancer. And so women were randomized. So this was, really a phenomenal achievement that he and his group randomized women with new intact breast cancer to 3 arms. They were randomized to different surgical treatments. One was total mastectomy, the classical standard. wide excision of the tumor, so removal of the tumor with a margin of normal tissue around it, or wide excision plus radiotherapy to the breast. And they used relatively small tumors, and there were some stratification features. So all patients had their lymph nodes removed from the axilla. All patients who had positive nodes then received very primitive form of chemotherapy, but still chemotherapy. Again, one of the early innovations in the treatment of solid tumors is to follow surgery with chemotherapy in order to address disease elsewhere. As you can see, you can get really good organ preservation. These, the breast in a woman by the time she's old enough to develop breast cancer is not very functional in terms of lactation and so on, but you can preserve a very nice looking breast, and women do well. So this is a testament to the idea, and this has been replicated, as I said, in many organs. So one can certainly do that, but what is the cost? And the cost, of course, is what's the likelihood that the cancer will then reappear at the same site in the breast. So these are the so-called IBTRs, in-breast tumor recurrences, and here is the rate of in-breast tumor recurrence in women who had removal of the tumor with radiation and women who had removal of the tumor without radiation. So radiation then was defined as an integral part of breast conservation treatment and is also a part of local treatment for many other solid tumors. In the rectum, it's very important. In the head and neck area, it's very important. So radiation is certainly another way of treating residual microscopic disease, because we recognize that surgery will not resect all microscopic disease. We resect mainly what's gross disease. We try to encompass the area of microscopic residual, but we don't always because we can't see it. So, so there is residual microscopic disease, and that is addressed with radiotherapy. Radiotherapy, of course, is not, it's something that we need to consider carefully in terms of risks and benefits, because it's not that hard to go through, but it does have some long-term consequences, and it has some very specific advantages. So I'll talk about that a little bit at the end if we have time. So these are the results of the NSABP B06 trial, and you can see that the pink, the blue, it doesn't matter which color is which endpoint, but the endpoints presented here are disease-free survival, distant disease-free survival, so how many women remained free of metastases in distant organs, and overall survival. And you can see that the randomization to mastectomy, to wide excision of the tumor alone, wide excision plus radiotherapy did not make any difference to these outcomes, which is what led Dr. Fisher to articulate that concept that it doesn't matter what you do locally, women live the same way. So live just as long and just as well in the sense that they remain free of metastases. So this was a little counterintuitive, but you have to remember that this study had about between 500 and 600 patients in each trial. For the time, it was a very large trial, and it was really thought to be adequately statistically powered. But the kinds of differences that emerge now with modern treatment are not necessarily detected with this kind of trial size. So what has happened since then, which has been very well documented and very well accepted in the arena of systemic disease, is of course randomized trials. You have one agent, it works. You have another agent, it might work better. Women are randomized, people are randomized in all sorts of settings. And then those randomized trials can be pooled in an overview or a meta-analysis, a concept you may be familiar with, but in breast cancer, it's been particularly well used because the breast cancer clinical trialists around the world have collaborated in contributing their raw data to a statistical center in Oxford. So that's the Oxford overview is sort of the nickname for that process. And that Oxford overview has produced a lot of interesting information and very useful information in terms of systemic therapy, but was addressed for the first time, well, I'll just show you this, is that even though we didn't see any difference in overall survival here, when you actually look at the women who did recur in the breast, they did see an impact on survival. So women who did not recur in the breast did better than women who did recur in the breast. And then women who'd recurred early in the breast did much worse than women who recurred later in the breast. So this phenomenon of in-breast tumor recurrence, even though the BO6 didn't show a difference in outcomes, does have a negative impact on the course of the patients who experience it. And so this, was a little counterintuitive, the difference between those two findings, and it was really resolved by this process that I just mentioned, the worldwide analysis of breast cancer clinical trials, where for the first time in 2005, the Oxford investigators actually looked at local treatment and local outcomes. In previous rounds, the analysis had been limited to systemic therapy and systemic outcomes and survival. So when they did this, they found that with sufficient numbers, so this is the power issue that I referred to earlier, with sufficient numbers, these are breast conservation results of many trials pooled together. These are about 15 or 20,000 patients, I think, in these pooled trials. You can see that difference that I showed you earlier. Women who get radiation down here have a far lower rate of in-breast recurrence than women who don't get radiation up here. So you have about a 5-year gain. At the end of 5 years, you see an 18% difference in these two arms. And then if you follow these women out to 15 years in overall survival, then you see a 5% difference. So that's the 1 to 4 rule that I mentioned earlier that has become accepted in breast cancer. And if there are sufficient data available in other tumors, I'm sure will work out the same way in other solid tumors as well, that although a local recurrence is not the same threat to the patient as a distant recurrence. Most women who recur at distant sites in the bones, liver, and so on will die of that disease. They don't always die when they recur locally in the breast, but that local recurrence does pose a hazard to their overall survival. And for every 4 local recurrences you can prevent at 5 years, you will prevent 1 death at 15 years. So local control is important. It takes a longer time to play out, and not all local recurrences translate into death. And the challenge now is to really sort out those patients and try to, figure out who is at risk of what and try to individualize our therapy better. So this is just again showing you that in-breast tumor recurrence is hazardous, and I won't go into the details of this. And this is just to show you that this in-breast tumor recurrence, the 5-year survival is 60%. So 5-year survival of distant disease is nowhere near 60%. It's probably, if we're lucky, maybe 15 or 20%. So, but when disease recurs in the lymph nodes, which is down here, this other local regional recurrence, you see that the survival rates are much lower, more in the range of what I just mentioned for distant disease. So when you read papers about local, regional, and distant disease, in breast anyway, and I'm sure in other organs too, it is important to pay attention to whether it's truly local disease that we're talking about in the breast, or whether it's regional in the lymph nodes. A nodal recurrence is a much greater threat than an in-breast recurrence. And the theories about why these recurrences happen in the breast are actually evolving, but I think there is an attempt to sort of stratify this phenomenon of in-breast recurrence into different biology to try to explain the fact that some women die after developing a local recurrence in the breast and other women don't. And the two sort of major ideas about this are that the local recurrence in the breast is a true local failure. It results from residual microscopic disease, and that's sort of supported by the idea that radiation eliminates many in-breast recurrences. So that the residual microscopic disease in the breast probably is a big contributor to some local recurrences, but it doesn't explain all local recurrences. And I was going to include a picture of a patient I operated on yesterday who illustrates this problem very well, actually. But the second concept is this in-breast metastasis, and that's what my patient illustrates, so I'll tell you about her. So this was a young woman who presented when she was 32, 35 years old. She was pregnant. She was in the last trimester of her pregnancy. She had a lump in her breast. It was a cancer. It was a decent-sized cancer. We decided to give her chemotherapy. She responded pretty well to the chemotherapy. She delivered her baby. She had her breast tumor excised. She had breast conservation. She came back a year later with a really nasty in-breast recurrence. It had essentially infiltrated the whole outer quadrant of her breast was rock hard, and it occurred at the interval of 1 year. So this kind of recurrence in a young person who had an ugly tumor to begin with and recurs very quickly is probably what's been termed this in-breast metastasis. And there's a lot of interesting experimental work that's going on to look at the tumor stroma in the tumor bed and to figure out the interactions between the tumor cells and the stromal cells and the way they talk to each other, and how the stroma might be the person who's really sort of popularized this concept and has done some of the work on it is Larry Norton at Memorial with his colleagues in the lab. But the idea that tumor stroma, the tumor bed, is sort of a sponge that attracts tumor cells, and tumor cells that are in circulation will come back and sort of metastasize and repopulate that tumor bed. So it's not really residual disease, it's disease elsewhere, and this is working like an in-breast metastasis. So those are the sort of two poles of how to explain in-breast recurrences, and in-breast recurrences are something that really, really bother breast surgeons, and they really, really bother surgical oncologists who work on other areas. It's our failure to treat the cancer adequately and not be able to prevent the local recurrence. So this is how we judge the adequacy of recurrence. So we spend a lot of time obsessing about the adequacy of recurrence, and this is one of the ways we use to judge it. So this is a specimen radiograph of a woman who presented with a mammographic density. She had a wire placed in her breast to tell the surgeon where the density was so that it could be excised with a rim of normal tissue around it, the wide margin, so that wide local excision. And you can see it really looks like a bullseye. This is really a very nice resection specimen, even if I say so myself. But the thing is that you can't tell that there's disease here, but microscopically there was non-invasive disease at this margin. And non-invasive disease at the margin is as bad a problem for local recurrence as invasive disease at the margin. In fact, it might be worse because invasive disease is more radiosensitive, and so when you follow with radiation, it gets wiped out better. But non-invasive disease is not as radiosensitive, and so it's a bigger problem in terms of residual microscopic disease. So this specimen, when you x-rayed it, one way, it looked really perfect. If you turned it around and x-rayed it the other way, so now this is the skin side of the specimen and this is the muscle side of the specimen, it still looks pretty good. And here was the DCIS. And that's what it looks like under the microscope. So you can see these inked edges. I'll talk about the ink in a minute, which is really something that is a horrible way to assess these. It's very primitive. We should be able to figure out a better way to look at our margins. But so far, that's the standard of care. So this is how we ink the specimen. So we take the x-ray first, try to make sure that lesion is centered in the specimen. Then we ink them. We use different colored inks for different surfaces, so the pathologist can tell us that it was the north, south, east, or west that the tumor was close at. And this is very imprecise and very unsatisfactory. And I think it's a problem that needs a solution. So in the break, maybe if any of you have ideas, or if I run into some of you, we can talk about it. So then this is a free margin where you can see the tumor here. And this is the ink on the margin. This is a positive margin where you can see these tumor cells reaching all the way to the ink. This is basically how we do it. It's very mechanical. You take out the tumor, you take a picture, you coat the outside with ink, you cut it in slices, put it under the microscope, and see if the tumor cells are close to the ink. This is a more sort of elaborate way of doing it. You x-ray all of the slices. We don't usually do that. This is how they do it at MD Anderson. I'm not sure they get any better results. But there's a big discussion in breast surgical oncology, and certainly I'm sure it's paralleled in other areas too. I know for sure it is in rectum, and to a lesser degree in stomach. All of the tubular organs, they have this discussion of what is a free margin? How free do you need it to be? A centimeter, 2, a millimeter, less, whatever. So in the breast, we talk in millimeters, and when the margin is positive, you can see that there's definitely a bigger risk of the tumor coming back in the breast. If it's free, around 5%. If it's involved, around 15%. But if you increase it from no ink on tumor cell, which is the classical definition, you don't really see a big difference. So here, for instance, where they defined free margin as more than 2 millimeters, the in-breast recurrence rate was about the same as when it was no income tumor cell. So this is something we need to improve on, and this is where I think we need real-time, intraoperative, molecular imaging of some kind that we can use to try to figure out how to improve the accuracy of our resection. Because it works both ways. Sometimes we don't take enough, and sometimes we take way too much. So we need a better way to measure this. So going back to the origins, I just wanted to tell you about a couple of things. So Jonathan, are we on time?
I think we're fine.
Well, I could take whatever you'll give me, but I can stop too. 10 minutes, okay. Okay, all right. So going back to this origins of the in-breast recurrence and implications for solutions, we talked about the two models for how breast tumors come back at the same place. And here, I think if with the true local failure, it's a resistance to radiation therapy, not, well, systemic therapy too, chemotherapy and endocrine therapy too as well, but potentially an indicator of failure of radiation. These cells are radiation resistant. And positive margins predict that risk of recurrence. So when we see that increased risk of recurrence when margins are positive, I think that's an indicator of residual disease being the culprit. That in-breast metastasis problem that I talked about is really related to high systemic burden. And circulating tumor cells are something that people have postulated for a century or more, have in fact measured in the past very tediously, but the methods for measuring them have improved, dramatically, exponentially over the last 5 or 6 years, and now it's a real clinical reality to draw some blood and see if there are circulating tumor cells in the blood. And we know that there are. And in fact, it's surprisingly early tumors can have circulating tumor cells, and the idea is that these cycle back to that tumor bed. So this is the basis of the residual disease. There are a lot of people who have done very painstaking studies looking at the extension of disease along a single ductal tree. So this breast was a lactating breast that was injected with sort of colored cement. And you can see that these multiple ductal trees exist that come together at the nipple here. And here's one ductal tree. And the idea is that when cancer happens, you might find it right here, but you'll actually see some early disease within this ductal tree. And the reason for the local recurrence is it wasn't all resected completely, or some of it progressed even after the resection. So that's sort of the local explanation. And here's an example from a pathologist who does these big mounts. So instead of having microscope slides that are, like this big, they have big mounts of like 8 to 10 centimeter slides, and they put big sections of the breast on there so they can actually look at a whole tree. And these are very low power demonstrations of how this disease is spreading really along the tree. And if you did this resection, you would get free margins. I've drawn this red square to show one could resect this disease and get completely free margins, but there would still be residual disease in that tree. And unfortunately, the tree is not something we can see with the naked eye and recognize during surgery. So that's the sick lobe theory. And then this is the metastasis theory. This is from a paper by Norton and Massagay. And basically, it's actually a very interesting paper. I don't know if I have the reference here. I guess I skipped the reference. I think it was published in 2005, maybe. Do you remember this paper?
I do. I actually heard Larry talk about it. It's all about mathematical modeling.
Yeah, but it's very interesting. It's simply written. It was in Nature or Nature Genetics. I think it was around 2005, Norton and Massagay. Yeah. And what the idea is that this, it's like fertile soil, that tumor stroma. Once the first few cells are transformed into malignant cells, they do things to the surrounding stroma to make it a fertile soil for those tumor cells. So they grow in that fertile soil like a patch of weeds, but then they also shed the circulating cells that come back and repopulate that fertile soil. And that's what Larry Norton calls like a sponge. I called it fly paper. He liked that too. But anyway, so this is really a systemic phenomenon and needs systemic solutions, whereas the other model that I proposed is a local phenomenon and needs local solutions. And it would be really great to be able to sort these out and be able to identify treatment paradigms for individual women that sort of accommodated these notions based on tumor biology.
The original reference is Nature Medicine, August 2006. Seems to be an update that's in...
Cancer Cell. Oh, Cell. It's in Cell, right?
Also one in Nature Reviews Clinical Oncology, which is clinical implications, June of 2011. But if you just look up Norden Massacre, the original hypothesis is there. Nature Medicine, August 2006.
Great, thanks. So, so here, positive margins are a predictor, and here, negative margins are irrelevant. You can do a really wide resection. Well, I suppose if you go past the change in the stroma according to the Massacre hypothesis, Norton-Massacre, you might get past it, but you, even if you see negative margins, good negative margins, and you have that altered stroma, it can still be an attraction for circulating cells to come back. So there are different mechanisms with different solutions being needed for each of these. So what has technology done for us to help address this problem? You know, we did it classically with palpation. Palpation is good. It works very well when you can feel the tumor. I actually have trouble persuading the radiologist that if I feel a tumor, I don't need a wire in the tumor. They think we need a wire in the tumor all the time. It's not true. But if you can't feel the tumor, you do need a wire in the tumor. And you saw the wire so those wires are placed in the breast in order to help the surgeon find the tumor. And the newest thing that's come along is MRI-based planning. So there are a lot of people who are extremely enthusiastic about MRI-based planning. The idea is that MRI sees disease more accurately, accurately in quotation marks, than mammogram and ultrasound do. And so if you can see all of the disease, you can plan to resect all of the disease and your patient will do better. So far, that is a hypothesis. It is completely unproven. And there are a lot of difficulties in implementing the image that you see on your nice PAC screen or on your films to the three-dimensional person who's lying on your operating room table. And so this MRI-based planning, so here's an MRI showing you, this tumor probably looked like it was 2 centimeters on the ultrasound. It looks like it's 4 centimeters on the MRI. So it should make you happy that I can take out a bigger piece of the breast and my patient will do better. That's not necessarily true, but the problem is sort of defining how much to take out, and it's really not easy to translate this to the patient. And that difficulty is demonstrated in this clinical trial, which was a trial done by, in the UK, they have these bodies that they have actually sort of something that's related to the medical council that tests new interventions. So they actually have an NIH-like mechanism for testing new technology. And they funded this trial called the COMIS trial, which was to look at the contribution of MRI in a very simple outcome, which is, does it reduce the need to go back for a positive margin? So if we don't know how big the tumor is and we just take out something that we think is reasonable, we would get positive margins more frequently. If MRI tells us exactly how big it is and we do our resection based on the MRI, we should get very few positive margins. So an MRI-based plan should reduce the need to go back to get additional tissue because of positive margins. That was the hypothesis. What they found, in fact, in the reoperation rate is that it was identical. And it wasn't a small trial. There were 800 women in each group. So this illustrates how hard it is to take that two-dimensional image, even if you can get it, you can synthesize it into a three-dimensional image by stacking it or whatever, you have to still translate it to the patient. So what we need is something in vivo in the patient that we can look at. So this is, this model I think holds for many other areas. Microscopic margins are very controversial. No one really knows how far we need to go. We tend to overdo it or underdo it, and we need to sort it out for multiple sites. The breast is a good model because it's easily accessible. You can reoperate, you can sort of confirm, verify, reject. whatever your plan, because you can go back easily and reoperate. You can get additional margins. In other organs, it's not so easy to get additional margins. But anyway, this problem exists really for all solid tumors as far as I know. And optimal margin width is controversial. So this is what I've been saying all along. I think I've been peppering it through the talk. And so I can actually stop here.
We sure?
Yeah.
Okay, thank you.
Oh, I can take my machine.
Seema, thank you very much for that talk. I was very struck. Can you show that MRI image of the breast again? I was really struck by that.
Oh, sorry, I'm going the wrong way.
So, just to this image here, so when you approach this patient, and so do you routinely do this at all, or are you not?
So I do it under duress. I'm actually not an MRI fan, and but the problem is that the radiologists recommend it all the time. It's in their template. So when they have a biopsy-proven cancer, their last line is always recommend surgical consultation and breast MRI. So you have to talk to patients about it, and I think there's some give and take there about whether the patient has an MRI or not. I use it intermittently. I don't use it all the time.
So this, how is this one of your patients?
No, this I actually got off Google because I couldn't get to it. I couldn't get to our server, so I got it off Google.
Right, so just a few things.
But it could be my patient.
It could be.
Who knows?
It is now, okay. These dots over here, do you think that this is also this hyper?
Yeah, so that's a big problem, particularly with premenopausal women. So with premenopausal women, we do try to get them to wait, and with a cancer patient, it's hard to get her to wait for anything, but we do try to get them to wait for the follicular phase of their cycle. So the best time to do the MRI is 5 to 10 days after the onset of menstrual bleeding, and the reason is that later in the cycle, there's a lot of non-specific parenchymal. Now, MRI, you remember, is a blood flow-based test, right? So the contrast, the gadolinium goes in intravenously, and it shows this cancer that you see is basically the blood is entering more rapidly, and it is hanging up in the cancer. It's not flowing out very quickly. So, so that's why it shows on the MRI. So the breast parenchyma of a premenopausal woman who's in the luteal phase of her cycle has a lot of non-specific parenchymal enhancement. So these are the things that you see. There's a lot of computation that goes into interpreting these, and they actually look at the dynamics of the blood flow to try to figure out. But that's also why it has such a high false positive rate. So that's why so many women return for additional imaging and additional biopsies following an MRI. And if my patients are going for an MRI, I always warn them to be prepared mentally for additional tests, that it's not necessarily cancer, but they might get recalled for testing. But that is a problem.
So the typical patient, is it the placement of the wire or the palpation that guides how far are you going around to get that free margin? How does it work in your practice? You know, when you're there,
so you try to get
surprised that you have to change the operation.
It's not that common, actually, to be surprised. We work sort of grossly, so we want a centimeter gross margin. That's what we go for. And then the other thing that's happened recently over the past, I've been doing it probably for 5 or 6 years, is this idea that once you've got the cancer out, so the tumor specimen that I showed you with the wire in it, in addition to the margin around that tumor that you saw on the specimen X-ray, we would take shaves of the cavity. So this is something I've been talking to Dr. Hoffman about, actually, Brian Hoffman. Oh, there he is in the back. Hi, Brian. So, so if one could have a system for actually, identifying tumor cells in that cavity, once you've created the cavity, to see whether there's any residual tumor in the cavity or not, then one could actually guide the resection to those areas and keep going in that direction until you get past the tumors. What we do now, because we do it blindly, we take shaves of the cavity in all directions, and then the pathologist tells us afterwards whether the tumor is at the new ink on the new margin once they've completed their examination. So yes, the rate for, I skipped some of those slides, but the rate of re-excision for positive margins in breast cancer patients is varies from 10% to 50%. And there are some very reputable institutions in this country that have reported rates of 50% re-excision. That's how often their margins are positive. And margin positivity, I mean, some of it has to do with how you define free margins. If you require only that there be no ink on the surface of the tumor, then there'll be fewer re-excisions because it's a lower threshold. If you want to see 5 millimeters around the tumor cells, between the tumor cell and the ink, it's a higher threshold, there'll be more re-excisions. That's actually, there are data to show that that happens. So, and it's not trivial. I mean, going back for another excision is a small operation, but for the woman, it's psychologically a real downer, and it costs money, and it really impairs the cosmetic result. So the nice cosmetic result that I showed you probably wouldn't be as nice if she had to go back for a second operation. So there are lots of repercussions just in the breast, which is a simple system. If you start thinking about the pancreas, you can't go back for another margin. I mean, it's just prohibitive in terms of the morbidity of the operation. Similarly for the rectum. For sarcomas, maybe you can go back because they're on the surface, but you shouldn't have to. You should really be able, so that's the wish list. You should really be able to figure out how much you need to remove that much and not more. So that's a very sort of nuts and bolts surgical problem.
I guess the other one other thing I was just understand, it's a stroma too. If we think this receding is
True.
occurring,
Mm-hmm.
if we had, we could image tumor. The question is how much it, we think about cancerization of fields, like the entire ductal tree. When you have cometocarcinomas that kind of just kind of go all the way through the tree.
Mm-hmm.
Do you have cancerization of the field such that you would, I mean, for many years, treatment of ductal carcinoma in situ has been mastectomy.
Sure. Yeah.
Well, there you've gotten rid of the field because you got rid of the target.
Right.
Was that overkill, or maybe they were onto something?
Well, so DCIS is cured by mastectomy. There's no question about that. Yeah. Yeah.
That's true. Headaches can cure by decapitation.
So that's going to go to my question, because if you go back to the old model of the radical mastectomy, studies have shown, while it's curative in some cases, its actual efficacy versus lumpectomy plus radiation is not dramatic. So there seems to be a baseline of cases or tumors in which you are seeing resistance. It's already disseminating, circulating tumor cells, whatever it is that's going on, so that even if you irradiate, which theoretically you're poisoning the sponge, you could be seeing elsewhere. So you might not come back to breast, but then you're pushing it out into studies that have demonstrated that. So the question is, maybe have you been looking at anything that would allow you to actually look at the phenotype of those tumors that where you're seeing this kind of 40% baseline of women that are continuously progressed, but regardless of they have you looking at like negative rate breaking down.
Right, so there are data, I just didn't really have time to go into all of that. There are data that the biologic subtype of the tumor it predicts not only distant disease but also local recurrence. And so there have been 2 or 3 studies now that have shown that women who have these triple negative tumors that have this basaloid expression pattern, that they do tend to recur more frequently locally and at distant sites. And so that's the kind of phenomenon where I think it's more likely to be just a metastasis in the breast rather than a question of residual disease in the breast. But yes, those data are developing. I think they're in evolution.
Any other questions for Dr. Kahn? I think we have a break now. Is that right?
Yes,
We'll take a break now.